I'm going to direct the question now to Dean Holly Walker to ask you, what are some of the things that we can do as a dean, for example, to influence the education aspect of this crisis, particularly with regards to underserved populations?
I think one of the most important things we can do is exactly what we're doing right now, but we need to do it with our students. So I think in order to address the opioid crisis effectively, we are going to have to get more interdisciplinary in terms of what we're giving our students. I think for nursing, for medicine, for pharmacy, for social work, and law, to be at the table together is absolutely essential. So for example, we've just had all of these discussions about where we're going in terms of healthcare policy in this country. So we have the current Affordable Care Act in place. We've had Medicaid expansion. That's been helpful in some ways, but we're thinking now about, will we continue with that law? Are we going to go under some new law? Will Medicaid expansion continue, or will it be limited to block grants, et cetera? Those are decisions that are largely being made by people outside of the healthcare field. They are being made by people, a lot of them are trained as lawyers, and many of them have never had any exposure to any of the science on the medicine, any of the science on the pharmaceuticals, any of the science in terms of understanding what it means to give culturally competent care to people. And I think when you turn out policymakers, and this is the unfortunate thing, is that law and many of our disciplines have been very siloed, very isolated for a long time. And what we see is that we turn out policy that is very siloed, right? And that doesn't really have the impact of what the facts are on the ground. And anytime you have policymakers that don't fully understand what the circumstances are on the ground, things that may stand in the way of people getting appropriate treatment, how it makes an impact when you pass a law that says, okay, on the 17th bed, and if it's for opioid use, you don't get access to these kinds of funds. We need to make it so that policymakers aren't just driven by politics, right? So much of the discourse now is driven around politics instead of around the facts. And I think that's partly because many of the people who are making policy don't have access to the facts that they need. And many of these laws are being written, unfortunately, by lobbyists and by staffers and by other people who just really either don't have the expertise or are solely in it for exactly the people who they've been hired to. As lawyers, that's part of what we do. We get hired to advocate for our clients. And if we're doing that without having the full information about the crisis ahead of us, we get policy that doesn't make any sense. So I think as deans, probably the most important thing we can do is begin to educate our students in spaces in which they can't say that they never heard. My students who are going into health law and into health law policy should never say they graduated from Howard without being in direct interaction with medical school students, pharmacy students, social work students, nursing students. When you have a full service university like Howard, not every university is lucky enough to be able to give their students that opportunity. But when you're in a higher education setting that can give your students that, I think we're under an obligation to absolutely make sure that we do that.
Great. Thanks again for having us. My name is Steve Miller. For those of you who just walked in, I'm the Senior Vice President, Chief Medical Officer with Express Scripts. With me today, we have a couple panelists, and we're going to talk about some of these policies that you've been hearing about. So I'm going to have each of you introduce yourself and tell us a little bit about your organization, but also about what brings you to today's conference. So Ken, why don't we start with you?
Good morning, everyone. My name is Ken Whittemore. I'm Vice President of Professional and Regulatory Affairs for SureScripts. SureScripts is the largest health information network in the country. We got our start with electronic prescribing 15 years ago, and that, as Dr. Miller has alluded to, is going to be important in today's discussion. But since getting involved with that, we've also branched out into other types of healthcare information technologies and communications, such as electronic prior authorization, medication history, and other things that can contribute to assisting with reducing the opioid crisis. So That's the reason that I am here today, to talk about that technology.
Great. Doug?
And good morning. My name is Doug Sheckelhoff, and I'm the Senior Vice President at the Office of Practice Advancement at the American Society of Health System Pharmacists. And our organization represents over 45,000 pharmacists that work in hospitals, health systems, and ambulatory care settings. We provide a lot of education, and the opioid epidemic and addressing this epidemic has been a big issue for us from a policy standpoint and from an education standpoint. We see a number of hospitals that are developing opioid stewardship programs, where hospitals are reviewing protocols, how they treat pain, and very actively having pharmacists and physicians work together to develop more effective treatment, avoiding opioids whenever possible and using non-opioid methods of treating pain. We also see many settings where, in clinic-type settings, where you have chronic pain patients, they're being referred to a pain management clinic that's being coordinated by a pharmacist, and they are, again, trying to manage their pain, trying to reduce their reliance on opioids, and ideally take them off of opioids as they're managing their pain. The Veterans Administration has a very successful model with this, and they've done it at a number of their centers around the country, and we're hoping that at least for chronic pain patients who use a large amount of prescription opioids, they're able to use these type of programs. And it's a real opportunity for pharmacists to be able to participate and be part of the solution.
Great. And before we get started, I want to give you a fair warning. We're going to be turning to you for questions in the next few minutes. So please start thinking of your questions. As a former academician, I will tell you that I can outweight you if you don't have questions. So please think about the things you'd like to ask either myself or our two panelists. So Doug, I'm going to turn to you first, and let's talk historically about what happened in hospitals historically when it came to pain, and then what has been changing over the last several decades.
Well, I think that, as you mentioned, and I think you did a great job of summarizing the issues in your presentation, but what we've seen in hospitals is that there has been a much more aggressive approach at trying to treat pain, and part of it was driven by the Joint Commission and trying to make sure that patients were quote, pain-free. And so very quickly, there was a movement towards opiates, and patients were managed through patient-controlled analgesia, oral medications, other ways of treating pain, and that has started to shift. And we've seen it over the last few years, and as I mentioned, very active approaches at trying to address what the initial treatment is for pain and how it's managed while they're in the hospital.
And then hospitals often run, outpatient facilities too. And so what have you been seeing happen in your outpatient facilities over the last decade or so?
Well, and as I mentioned, we see more pain management clinics springing up. We see a number of hospitals that are actively looking at what types of discharge prescriptions they're sending out for pain management. Some hospitals that are actively trying to minimize or to the degree possible eliminate sending patients home on opiates, and really trying to look at other modalities, other ways to treat pain. And for patients that come back that continue to receive opiate medications, trying to get them into a pain management clinic so that they can seek other ways of managing their pain. And what we have found is that I think physicians, nurses, pharmacists are all much more aware and much more involved in looking at non-opiate solutions, where 5 years ago, 6, 7, 8 years ago, that was not so much the case.
So Ken, the states have developed what are called these PDMPs, the prescription drug monitoring programs. Can you give us a little idea of what these things are, how they work, are they effective?
Sure. So in attempting to respond to the issues with regard to opioids and other drugs of abuse, most all of states, in fact all states now have a prescription drug monitoring program of one type or another. The idea behind, or the way these programs operate, is that pharmacies are required to provide information with regard to their dispensing of controlled substances to a central authority, which combines all of that information from all the pharmacies in a locale, and then makes that information available to practitioners, to pharmacists, and in some cases also to the law enforcement community, which is probably a whole other discussion as to whether that should take place. Initially, these programs were made available on a voluntary basis, meaning that they were out there, they were available for prescribers and pharmacists to use, but nobody was required to do that. And in general, they weren't very, very effective because of the fact that the interfaces that are available for the prescribers and the pharmacists to access this information are not integrated well into their workflows. So seeing that these types of programs really weren't having the effect that the states were looking for, some have moved toward mandating or requiring that if a prescriber is going to prescribe a controlled substance, they must check the PDMP database for a patient before they write those prescriptions. And now there are 36 states that have some type of mandate that prescribers have to check these prescription drug databases. The issues that remain, there has been concern about the fact that there hasn't been enough sharing of this information across state boundaries. And certainly in an area here where you've got Maryland, D.C., and Virginia, that is something that is very much a factor. There have been efforts over the past couple of years, and then there's in fact a program that now connects more than 40 of the PDMP programs so that prescribers can have access to this information from other jurisdictions than where they are practicing. The other issue is not all of the PDMP programs originally allowed pharmacists to access this information. We're seeing a movement now that is allowing that. The laws are changing, the regulations are changing to allow that as well. And finally, getting back to just the ease of use, there continues to be a problem in that in most cases, a prescriber, when it comes time for them to access a prescription drug monitoring program, they have to leave whatever they're doing, their EHR system that they might be using, open up a separate portal, and access the information that way. And today, with the time pressures that are associated with medical practice, that really makes it difficult. So there's now a trend toward making that information available via interface right into electronic health records. But that's relatively new in the overall process.
Great. So one of my big pet peeves in the opioid crisis has actually been that people pay cash for opioids. If you think about prescriptions, the number one prescription that people pay cash for is the $4 generics. But the second most common prescription that people pay cash for actually is opioids. And the reason they do it is that it doesn't show up in the system. So when Ken talks about these systems, if you pay cash, often they don't show up in the system. If you think about why a pharmacy is open after midnight, it turns out the most common prescription they fill is actually cash claims for opioids. And the pharmacy does it for two reasons. One is if you pay cash for a drug, you pay the highest price. Remember that your insurance company, if you show them your card, your insurance company has negotiated a 20% discount or some sort of discount. If you pay cash, you don't get that discount. And the other thing is that after midnight, no doctor's office is open. I can't call to see if the script is actually a legitimate script. And so these are some of the most profitable claims that a pharmacy will fill. And so when you think about why you have the window open after midnight, it's not because, if you have a legitimate reason, if you go to an urgent care center, the urgent care center will almost always give you a starter pack of the painkiller that you need. It's not because you need it that night. It's often because these are actually some of the fraudulent claims that are coming through the system. I give you that prelude because, Ken, what is your solution for trying to get the cash claims into the system?
In terms of our particular system, the way that we get at that is to collect both dispensing information from the pharmacies and then also paying claims data from the PBMs. And so by combining those two data streams, that brings all of that data into the prescriptions and makes it available to the prescribers.
Yeah, but then the other solution I'm trying to get at, which is in the president's recommendation, is electronic prescribing of controlled substances. Because if you are required to prescribe it electronically, it makes it irrelevant how they pay for it. So what are you all doing when it comes to electronic prescribing of controlled substances? And can you talk about some of the early successes you've had?
Sure. First off, I should probably just give a little background. So you have basic e-prescribing, and then you have electronic prescribing for controlled substances. Basic e-prescribing has been available, as I said earlier, for about 15 years. It wasn't until 2010 that the Drug Enforcement Administration issued a rule that would even allow the electronic prescribing of controlled substances. So it's only been in the past 7 years that this has been a possibility. In addition to that, the states at that time, when the DEA issued its rule, about half the states didn't allow electronic prescribing for controlled substances. So we had to do a lot of work with a lot of folks in the industry and the professions to get those rules changed. But just to level set, because I know there's confusion about this, everywhere in the country, every state and Washington, D.C. does allow electronic prescribing for controlled substances. I mentioned that there's a difference. There is a much higher level of security and authentication that's involved when you e-prescribe controlled substances. And there are additional requirements that have to be met both by electronic health record companies, by the providers themselves, and by the pharmacy systems. So even though e-prescribing in general has been available for a while, and e-prescribing for controlled substances has been allowed for 7 years now, it has taken a while to get those technologies up to date and to get to the prescribers in particular to go through the identity proofing process that they have to do in order to get issued the credentials such that they can prescribe electronically for controlled substances. Overall, nationally, about 68% of providers are e-prescribing. About 19% have taken that additional step and become enabled to e-prescribe for controlled substances. So we have quite a ways to go in that regard. But one of the outstanding successes, I would say, would be what the state of New York did several years ago. In 2012, the state passed a law known as iStop, the Internet System for limiting over-prescribing of controlled substances. And that law did a lot of different things, but the two main things it did was it changed the prescription drug monitoring program requirements to require prescribers to check the PDMP program before they e-prescribe. And then it also mandated e-prescribing across the board, not just for controlled substances, but across the board. That mandate took effect March 27th of last year, so we've got about a year and a half experience with that. And in the state of New York, now over 90% of prescribers are e-prescribing, and 74% of them are enabled to e-prescribe controlled substances. We're still kind of analyzing data and trying to determine exactly what the effects of that have been, but if you look at what happened after the PDMP mandate took effect, within about 6 months, and this actually predated when e-prescribing was required, within about 6 months after physicians in New York were required to check the PDMP program before prescribing controlled substances, doctor shopping was reduced by 95%. So that was a very dramatic effect on the PDMP side. In terms of the electronic prescribing of controlled substances in the state of New York, that is probably over about 70% now. In fact, one of your colleagues at ESI mentioned to me just about a week ago that 97% of the prescriptions that you're seeing from the state of New York are electronic. So it can be done, and New York has shown that it can be done. And the reasons why you want to e-prescribe for controlled substances, it basically reduces fraud and abuse. It reduces the opportunities for patients to game the system. These prescriptions go directly from a prescriber to a pharmacy with no one intervening. And so the level of security and authenticity is very high. One of the other things that seems like a minor point, but after watching Dr. Miller's presentation, I think this is even more relevant, is in the past, particularly in the surgical realm, physicians had a tendency to prescribe larger quantities because they wanted their patient not to have pain. And a lot of the prescriptions that they would issue are Schedule II controlled substances that can only be issued on written prescriptions. And so the tendency was to give a larger prescription because they didn't want the patient to run out because it couldn't be refilled. Now that electronic prescribing of controlled substances is available, physicians can be more confident in reducing the quantities of the prescriptions they're writing, because if they need to give the patient more, they can do that electronically without having to go through the problem of trying to get to them a written prescription, which in many cases can be very difficult to do. And so it seems like a minor point, but this is an issue that I think can help out in ways we've already discussed.
Yeah, so I'll add a little color to what Ken said. So my company, Express Scripts, we handle the pharmacy for about 80 million Americans. When you look at the number of prescriptions we are processing that are electronic, it's now up to almost 85%. But if you look at the number of prescriptions for controlled substances that are going electronic, it's 14%. So think about that gap. That's an enormous gap, and it's all of that is a potential for fraud, waste, and abuse. And so by having laws like New York, where you require electronic prescribing of controlled substances, you actually eliminate the need for what happens with a cash prescription, because now we have visibility to every prescription. It allows us to identify which doctors are prescribing how much, so you can develop bell-shaped curves to look at not only which doctors are over-prescribing, but you can do it by their profession. So you can say, this person's a hospice doctor, this is an oncologist, of course they're prescribing a lot, but why is this dentist prescribing so much? It turns out, for instance, that one of the ways narcotic addicts get their drugs is they go to dentists, because a dentist cannot actually tell you if a particular tooth is causing you pain or not. And so until they can give you definitive therapy, they will often put you on narcotics. And so it turns out for every $1 that is spent on a narcotic in the United States, $41 is spent by the person to obtain their narcotic, by going to the emergency room or going to the dentist or going to the back surgeon or someone else. And so this is why that number is so large when you look at the total cost to society. And so the things that Ken's talking about of having electronic prescribing of controlled substances, if you think about it, if you don't have new money and you want to do something that's innovative that can make a huge difference, it costs society absolutely nothing. Requiring them to electronically prescribe controlled substances is crucial. But I'll ask you a follow-up, Ken. So who is resisting this? Why isn't it happening across all 50 states?
Well, initially what slowed the process was the fact that the DEA made very rigorous requirements, particularly on electronic health record systems. And this rule came out about the same time as another federal initiative known as the High-Tech Act came into being, and there were meaningful use requirements that electronic health record companies had to meet in order to allow their users to be eligible for the meaningful use incentives. And these were very significant payments. So this is something that the electronic health record companies couldn't ignore. Of the criteria that the electronic health record companies, or EHRs, had to address for meaningful use, one was e-prescribing, but they specifically exempted electronic prescribing for controlled substances. So what that meant was that a lot of these companies just kind of put that on the back burner and said, we'll get to that when we can. So for a couple of years, there just wasn't a lot of initiative on their part. Interestingly, because of the importance of the state of New York and the fact that that mandate took effect a year and a half ago, as I shared, that really drove the EHR community to adopt e-prescribing for controlled substances. I think it's 1 out of every 12 physicians in the U.S. is in New York. So if you were going to offer a service to physicians, and you wanted to take advantage of that large part of the marketplace, you had to do what was necessary for New York. That's now behind us. Now I think it's mainly a question of inertia. We've done analyses at our organization, and we've determined that of the physicians who are currently prescribing, and again, that's about 70% nationwide, 95% of the systems they're using have the electronic prescribing for controlled substances capability available. It just has to get rolled out to the end users. So the software has to be updated, and then the physicians have to go through the process of identity proofing, which is a one-time affair, and it's not that costly. But the combination of, again, just getting that software out there and getting the docs and their staffs to do what they need to do is pretty much all that's slowing things up right now.
Great. So, Doug, you can no longer be a tourist here. I'm going to ask you some. So, the other thing is, Ken mentioned the importance of getting to all the docs. It turns out the hospitals get to all the docs. That is, every one of us, both pharmacists, nurses, and physicians, almost all of us have training experience from the hospitals. So, what are the hospitals doing as far as education on the narcotic crisis and training on appropriate use?
Well, I think there's a couple of things. One is that there is much more education and training about recognizing substance abuse or people that are seeking prescriptions that are fraudulent or inappropriate, and being more proactive. And you hear many stories about physicians seeing patients in the emergency department, and how aggressive patients are and how physicians respond to that, and other caregivers. And I think there's much more education about how to identify and deal with those types of patients and behaviors, and being able to access the PDMP programs and so forth. So part of it is around recognizing potential abuse and dealing with that directly. The other side of it is around education on better ways of managing pain. And so for many years, it was the easiest path was to just write for an opioid, and the patient's pain would be addressed, and you would move on. It's more difficult sometimes to look at other ways of treating pain, and for difficult to manage patients, many times there's referrals that are required, and there's other ways to approach it, but it does take more time and more effort. And I think there's much more education, both as physicians are being trained and pharmacists, on how to better manage pain. And utilize those types of programs. And as I mentioned, even protocols and policies and ways that it's being applied in hospitals is evolving as well.
So in the hospital setting, many of these patients are actually presenting themselves to the emergency room feigning pain. There are certain conditions in which you can't tell if a person's pain is legitimate or not. For instance, there's no test that you can do on back pain, for instance, no x-ray or anything that can tell you if the pain actually originates from the back or not. So what options do hospitals, and especially emergency rooms, have when it comes to these patients that are feigning pain?
Well, I think there's no question it's a difficult situation. And I think that as we look at many of the policies that are coming out, many of the things that you described that are already happening, and even as new policies and new things go into effect going forward, we have to be careful that we don't have the pendulum swing too far, so that patients who truly are in pain don't receive medications. And so it's always a balance. And I think that, access to history, the patient's medical record, the PDMP information, all of those things help inform. They paint a picture for the physician as they're evaluating the patient. And so I think that's an important part of it. But many times it's a difficult situation.
So I've heard that some hospitals are actually now advertising that their emergency rooms will not dispense narcotics as a way to discourage narcotic addicts from coming to a particular facility. Do you all have a stand on this, or?
Yeah, our approach is what we advocate for is really that the hospital look at their protocols, that they involve pharmacists, physicians, nurses, and look at it from a holistic standpoint. I think trying to be an opioid-free emergency department, it might prevent some individuals from coming to that emergency department seeking prescriptions, but in some cases they may need to send people out on opioids. It may be really what's best for that patient. So I think, again, it's taking all those things into consideration, but we do hear about more and more hospitals that are taking that approach.
Yeah, as you all know, a pendulum is rarely in the right spot. And unfortunately, in this situation, I believe we're going to have a trouble finding that right spot. So when you think about the training that we're providing to physicians, nurses, pharmacists in the hospital, how do we actually get them to that point where we still treat patients appropriately and we don't overreact to the current crisis?
Yeah, that's the million-dollar question. I think it's difficult. I think just the awareness that's coming. I think having a program like this helps make people aware. I think the White House Commission has a number of recommendations, as you mentioned, over 50 recommendations. Many of them are around education and helping either train students, residents, and practitioners about pain management. There's so much more focus on it. I think they're going to be much better prepared and much better able to manage patients going forward.
So I'm going to ask you a really difficult question, and that is, do hospitals have the resources to actually treat people who are addicted to opioids?
Well, I think it is a tough question. I think many of these patients have comorbidities and they have a lot of issues that are going on around this. And I think many times treating patients who are addicted to medications, they often don't stay in the hospital too long. Some do, but most of them are really trying to remain outside of the hospital. It's just really looking at the channels and the ways that they're getting access to medications. It does require resources, though, and especially in the emergency departments where they're already very busy, and the time that it takes them to handle these patients can be significant.
Okay, I'm going to give you a 2-minute warning. I will continue to ask questions unless you do, so I have one more for Ken, and then we're going to open it up to the audience. So please think of your questions. We would love your participation. If you have a question, you can step up to the microphones that you see in the aisles. Otherwise, we'll repeat your question if it's difficult for everyone to hear. But Ken, when you think about the integration of your systems into the hospitals, because many of these episodes start in a hospital or the hospital needs this information in the emergency room, how are we doing with integration of data?
We do have a product that is distributed to hospitals that makes medication history information available. It's used primarily in the acute care settings, the emergency rooms. But that is a widely used product now and gives them not only information with respect to controlled substances the patient might be taking, but all of their pharmacotherapy.
Great. And we'll start with the gentleman over here. If you can state your name and let's hear your question.
Good morning, gentlemen. My name is Dr. Bradford Wilson. I'm a geneticist by training. However, I've heard the discussion about, sorry, can I not be heard? Okay. Thank you, gentlemen, for attending this event. And I've appreciated the discussion about the regulations and changes in hospital settings. However, there was only brief mention about what many may consider to be the elephant in the room now with regards to the pain clinics that have sprouted up all across the country and that were highlighted in the recent piece on 60 Minutes a couple weeks ago. And I just want to get the panelists' opinion on that and the role of those pain clinics as well as the 3 distributors that were named in that piece as well.
Yeah. So great question. So I'll repeat his question for those in here, but his question is really about the role of the pain clinics that have sprouted up around the United States and the distributors. And as I mentioned before, I don't think any of us are without our fingerprints on this. We at Express Scripts have actually been able to identify bad doctors, bad pharmacies, and patients that need assistance for years. And we've offered this information to both the payer community, but also to law enforcement, and have actually helped close down many pain pharmacies around the United States and have taken out of network pain clinics. But I'll give you one example. Broward County around Miami has 64 different pain clinics. And as you know, these pain clinics are really pain treatment mills where a patient will come in and the doctor will sort of coach them through answering the right questions. And so this actually needs to be addressed, and it's actually in the President's Commission's recommendations. As far as the distributors, their behavior has been reprehensible. That is, the distributors for years have sat on data where they were selling just narcotics to particular pharmacies and nothing else, and those pharmacies were calling themselves pharmacies, and they did nothing with that data. And so 60 Minutes obviously exposed that, and there's even been, softening of rules around these things. And so this is why I say we all have got to be involved, and we all have culpability to this, because these pain clinics shouldn't exist. There are legitimate pain clinics, there are illegitimate pain clinics, and we have to do a better job of identifying each and route them out of the system. And the same thing goes for distributors. We've got to hold them accountable. But even the pharmacies, as I said, I'll give you one quick example because we have a lot of questions. When you look at pharmacies in the Orlando area, the typical chain pharmacy dispenses $75,000 a month in opioids. There was one pharmacy in Orlando distributing $2 million a month, and this was a chain pharmacy, a national chain, very famous pharmacy, doing $2 million a month. Do you believe their manager didn't know what was going on? They were probably getting rewarded for their great distribution of opioids. So your point is spot on, and we got to close that gap. So thanks for the question. Yes, ma'am.
Hi, my name is Naomi Seiler. I teach health law and policy at GW. I have a couple questions about PDMPs. I understand that there is extensive evidence that they reduce overall numbers of prescriptions, but I wanted to know if you're aware of any research on follow-up of patients who are identified by PDMPs or who indirectly are affected by reduced prescribing, either chronic pain patients who are not getting alternate modalities of care, or folks who are being identified as perhaps having a substance use issue, but not all PDMPs are necessarily linking people to treatment. Do you have any information on research about follow-up with patients who are in need, either with pain or substance use disorder, or both?
Ken, do you all have any of that data? Or?
No, I'm going to pass it back to you for that.
Doug? I don't. So I'll give you a little bit, unfortunately. So it turns out that the PDMPs have only been of so-so success for a bunch of reasons. One is, remember, the PDMPs don't share across state lines, and when we look at where the worst pharmacies are for pain abuse, they're on state lines. They're getting their prescription in one state and getting them filled in another state. When I told you about our predictive models, one of the data points we use is how far is the pharmacy from your house or from your doctor's office. It turns out that people who abuse actually don't get their prescription filled in their neighborhood. They go outside their neighborhood to do it.
Yes, hi. My name is Mohammed Garatmal. I'm a second-year psychiatry resident. My question is, in less than a 2-year experience, I have the most difficult patient we have are pain-seeking patients who are looking for drugs, and they come and put tantrums and all. You see them on pain medications for more than 10, 15 years. The question I have is if there is any interactive system between the prescriber and the pharmacy who dispenses the medications to kind of like put a limit so that once a patient comes in for their 3rd or 5th or 20th prescription, the pharmacy will call the prescriber and say that even the doctor may not know who the patient is, maybe a dentist who had never seen the patient before, but they will get that information and go through the secondary either step or paperwork to see that, or think twice that is this patient really needs a opioid or this one need drug seeking. He is a drug seeker.
Great question. I'll start, and Doug, you may want to add to this. We now actually have the ability to what we do call lock a patient into a single prescriber. So we can identify someone who's been visiting multiple physicians or multiple caregivers to get a prescription, and now the federal government even allows us to do this with Medicare, where we can lock a patient in to just one prescriber. So they can't get a prescription from, so even if they have a toothache, they still have to go to the primary to get the prescription. And so commercial plans will pay us to do that, to lock people in, but also the federal government does now. Doug, I don't know if you want to make...
I'll just add that I think that the power of data is going to be very significant here, and it's come up a number of times. PDMPs, utilization data that has been available but has not been really utilized. As we get more data, as we know more about how these drugs are being used, I think it is going to be powerful. One of the challenges is, though, that nobody has really owned the problem. And so people knew about different aspects, but nobody had accountability for trying to address that. And I think that hopefully with the White House Commission and some of these other policies that come out, there will be better coordination, because right now there's just a patchwork of state policies and actions. There's payers that are involved with limiting prescriptions. There's so many that are taking different actions. Individually, they're all well-meaning and probably on the right track, but the lack of coordination sometimes makes it difficult to be as effective as it could be.
Great. Let's go over here.
Hi, I'm Tom Melman. I'm a psychiatrist, and I direct research programs at the College of Medicine. First of all, thank you all for very informative presentations. I did want to comment, though, Dr. Miller, about you were kind of talking about the patient who's feigning symptoms versus who has legitimate symptoms, and I'm wondering if that's kind of an overly binary way to look at it. I mean, clearly there are people whose motivation is to obtain narcotics, and you know, and it's and it can be transparent what they're doing. But I also get the impression that many patients who we might think of as not having, quote, legitimate symptoms believe they do to some extent, and it forces the clinician to make a call that actually is very complicated determinants. But I wonder if a way out of that, I mean, I just raised the question with this particular example that you used, is an acute exacerbation of back pain, something I'm personally familiar with, is giving a narcotic on a short-term basis, is that really an evidence-based practice? I mean, I would argue it's not. I think there are studies showing initiating narcotics versus not have no impact on, or maybe even a detrimental impact on, the longer-term outcome. And, couldn't an emergency room have protocols that, maybe muscle relaxants or non-steroidals and rest and stretching are the way to deal with those patients, without having to, say, well, this one's legit, this one's not legit.
Yeah, so I will tell you, guilty as charged. You are absolutely right, and I oversimplified this. When people are seeking
to make a point.
Well, but when people are seeking drugs, they're not just in physical pain; they're in psychiatric pain, right? And when you look at the degree of despair that many patients who are drug seeking are suffering from in our society, they have real problems, and so they're asking for these products, not just because of their physical pain, but it's also their psychiatric condition and their social condition. And so
and of course
I don't
we're not
want to
relieving their despair by giving them narcotics.
And so I agree with you 100%. This is actually such a complex problem, and we as providers want to be sympathetic. We go into this because we want to help people. And so I agree with you 100%. This is so much more complex, and this idea that we're just going to shut the door on these people and let them suffer is not going to be a good solution. And we're just going to drive people to maybe even worse drugs, illicit drugs. And so the complexity of this problem is exactly as you stated. And so I apologize if I've oversimplified it, because you're exactly right. And I do believe, though, that science-based, data-based protocols are going to be incredibly important for us providers, so that we're actually treating people with greater degree of science and less degree of emotion.
So I could quickly slip in, you brought up some very interesting data, like, for example, the majority of people who go down the opioid trail having started with other people's prescriptions. Could you give us some idea of how such data are obtained? I mean, with illicit activity, are these surveys of people who present for treatment, or it must be a challenge to get that kind of information?
Yes, so that data is from the CDC, and so what the CDC did is they took people who were identified as using drugs either through emergency rooms, treatment centers, or other things, and they asked them where they started, how did they start on this pathway? And that's where 70% of people identified that it wasn't their own prescription, but it was someone else's prescription they took from out of the medicine cabinet, friends or family. Yes, ma'am.
Yes, good morning. My name is Gladys Mendez. I'm actually a student here at Howard University School of Social Work. and I also work in the pharmaceutical industry, very close to the pharmacists. I've noticed that there is also a lack of communication in a triage way. So between patient that is being treated, the pharmacist, and the physician that is prescribing at the time. How do you think that would be, we could make that better? Because I think that if we start also there by educating the patient and following up also from both the person who is filling my prescription and the person that is treating me, I think we could have also better outcomes because education is very powerful. And I think we should also start looking at it that way.
Yeah, that's exactly right. I think that if you look at the White House Commission, there are specific recommendations not only about educating caregivers, but also, or providers, but also educating patients, families, and caregivers. And that's a very important point. I think, Dr. Miller mentioned the letter. The impact of a simple letter. Think about the impact of a more broad and extensive education of patients, how to treat their own pain, how to manage their symptoms, the risks that are involved with taking these medications, and the benefits to them of trying to stop taking pain medications as soon as practical or as soon as possible. The American Hospital Association came out with a toolkit about a month ago. It had a number of different resources and tools, but one of the key points in there, again, was for hospitals to develop educational programs for patients, families, and caregivers, exactly to your point.
Just one more comment. Also, I think it's important to take in consideration the cultural lens, because I deal a lot with Latino population, and they don't even know what Percocet is, what it's for, and
Great
they
point.
take it. So,
We're going to
thank
give you the last word, but we're going to make it really short. So.
Okay. Good morning, and thank you for the opportunity. I'm Faisal Urdu. I work for MedStar Health. I'm a former regulator for the District of Columbia. So, as I see this discussion, the regulatory body in general, for example, for drugs, FDA does regulate the manufacturer. Also, they also regulate the distributor, the wholesaler actually, and the state also regulates the wholesaler, and then you have the distributor, and then you have the retailer. All of these different entities are regulated, which means that the FDA knows how much drug is being manufactured in this country, and we also know how much of the wholesaler is selling. And when it gets to into the district, we know exactly how much of this drug is being trained into the district, and we are responsible for that. And then to the retailer, to the pharmacy, the actual retail pharmacy, we know exactly how much drugs are being brought into the city, and then who is prescribing it to who. This is all known. And then we have prescription drug monitoring program that we put together in the District of Columbia about 3 years ago. The National Board of Pharmacy actually has a platform that shares information across state line how much of these drugs are being distributed. And then we looked at, as you know, physicians are not pharmacologists. So we initiated the continuing education programs where these physicians are actually educated in prescribing, because most of their information is coming from the pharmaceutical detailers. And then in the district, we actually license these detailers so that we know exactly what information they are being communicated to the physicians. So the issue here is that, and then in our regulatory agency, we might have about 3 people to regulate all this. So it's not about adding more information or more things and more things. I think information overload is the problem. If we can fund these regulators, I know exactly for that. And then enforcement, you won't believe how difficult it is to find someone who has a cash business. I've had problems with that. A cash business who has been people coming out from California and North Carolina, South Carolina to get their drugs in the District of Columbia. And we go to, we try to enforce that and go to courts. It's a very difficult process. So how do we fund appropriately for these regulators so that they are able to do their jobs? I think that's where the problem is. Thank you.
Great question. I'm going to end this right on this, and that is, we don't have time for any more questions, unfortunately, but data is not knowledge. We have got to take all this data and turn it into actionable knowledge. And so you're exactly right. We're going to have to be, we're not going to get a lot more funding for it, so we're going to have to be much more innovative in how we do it going forward. I want to thank you all for your participation. I want to thank our panelists, and enjoy the rest of the day. Thank you all very much for being here.